Happy Monday, y'all, and welcome back to another episode of Excuse Me, Doctor. Thanks so much for joining. My name is Dr. Melissa Clark. For my Be Health Empowered family that watches all the time, you know me as Dr. MEL. Welcome to all the newbies who are tuning in for the first time, because we are here for you. We are here for the entire Be Health Empowered family to make sure that you are getting the information that you need to make wise health decisions, not just for yourself, but also for your family and even for your community. So we are going to have a fantastic show this evening. Please remember, especially if you're tuning in for the first time, to hit that like button if you're feeling us on Facebook, that subscribe button if you're feeling us on YouTube. We really appreciate you for it. And then, of course, for my Be Health Empowered family that always watches, I know y'all are waiting for me to bring on my two incredible co-hosts, Miss Lila Mays and Mr. Wayne Bruce. Come on through. How y'all doing?
Good. Hi, Dr. Mel. Hi, Wayne.
Hey, Lai. How are you? Dr. Mel, I like to take this opportunity just to say that, I really appreciate my work family here at Excuse Me, Doctor. I think everybody, needs to appreciate them. And really, Lila, I mean, it is just always a party when we have her around.
Always a party. We can recognize this. Everything seems to have a day. We should declare this Happy Work Family Day.
Happy Work Family.
Well, I appreciate.
What does that mean in Jamaican? I don't know.
Party means party.
Party, right? It means party.
That's cool.
Exactly. Well, I am happy that y'all are back. What do we have going on tonight? What do we have teed up?
Dr. Mel, I think it's fair to say that all three of us have been affected or have had loved ones be affected by cancer. So it's a topic that hits home, and nobody in our community likes to talk about it. But
yeah, the word alone strikes so much fear that we tend to not talk about it enough. But the truth is, we have to talk about it if we want to beat it.
Exactly. That is so true. And so that's why tonight we're talking about cancer. We're talking about making smart choices. We're talking about, prevention. We're talking about the myths that are out there. And we have a perfect person who's going to walk us through all of that. Dr. Otis Brawley. Not only is he a top cancer expert, but I've talked to him. He is a straight shooter. He pulls no punches. We're going to be getting some really great information tonight.
So I need to know why Black folks are dying. That's what I need to know. Why Black folks are dying and so affected by cancer. I mean, I want to know how we can protect ourselves and protect our family members.
Exactly. Yeah. So if you ever have any questions like, should I get that screening, or what really is my risk for cancer, you are in the right place.
Right. So don't go anywhere. Lock it in. We're going to get to Dr. Brawley soon. And in the meantime, start to share, because I know the likelihood is that you have somebody in your life who's been affected by cancer. They should be listening to this too. So go ahead and share right now, while you have a couple of seconds to do that.
Yeah, you know what, Doc? I'm going to tell you. They say you shouldn't say share. But, like the algorithms, something with the algorithms. You shouldn't say share. But look, this is what I'm going to say. Pass it on. Okay. Don't have to share it. Pass it on.
Pass it on. Okay.
Pass it to your neighbors.
That'll work.
So look, we always have to go to the week that was in health and wellness.
Yes.
And what a week it's been.
What a week it's been. Let's jump right on in here. Vaccine for dementia. So if you are over 50, you have probably gotten a message to get the shingles vaccine to prevent shingles. I just had my second dose a couple weeks ago. That's a whole nother conversation.
Okay. All right.
Not a fun time, but I've been told much better than coming down with shingles. Anyway,
Yes.
it's really serious because I know people who've had it and it's really painful. It's no joke. But what is this about vaccine for shingles preventing dementia, Dr. MEL?
Well, you're right. Shingles is the vaccine does hurt, but shingles is way more painful than that. It happens to people who had chickenpox as a kid, and that virus stays in your system, and then under times of extreme stress tends to come out, and you get this really blistering rash that can lead to scarring and other complications, even blindness. So it's really important to get the shingles vaccine. But then some new information has come out. Researchers analyzed the health records of almost 300,000 people in Wales, in the UK, and they have this vaccine rollout policy, whereas if you're 80 and over, you don't have to get it. If you're 80 and under, you do have to get the shingles vaccine. And so because of this, they were able to create these comparison groups.
Okay, so researchers were able to compare people who were just a few months apart in age who did and didn't get the vaccine.
Exactly. Right? Yes, okay. That is right. And to everyone's surprise, they followed these people for 7 years. They saw that vaccinated individuals were 20% less likely to develop dementia compared to their unvaccinated peers.
Wow. Oh, why would that be? What does shingles have to do with dementia?
So it turns out that the virus that causes shingles, like I mentioned, it lives in our nerves. And this is just speculation that it might contribute to dementia by promoting inflammation or directly damaging the neurons that are in the brain or the nerve tissue that's in the brain. And so by vaccinating, it might prevent reactivation of this and therefore, prevent harm to the brain in that way. So while the study doesn't, prove that, this vaccine definitely is, decreasing the risk of dementia, it just seems like there's a correlation. It does seem to provide strong evidence that, this might be a good thing to explore in the future and do more studies on.
Okay. Well, I hope this bears out, but the bottom line is get that shingles vaccine if you don't want shingles.
Exactly. Yeah.
All right, moving on. Measles spreading. Listen, this is probably going to come up a couple more times in our recap because this is
correct. And it's not. It's actually not funny. The sound is funny, but measles. Right. Measles is, last time we talked about it was 300 cases. Now it's 700 cases. And it's all because of low vaccine rates for measles, mumps, and rubella, that MMR vaccine that kids are supposed to get. We're seeing in places where that vaccination rate has dropped below 95%, which is what's needed for herd immunity. That's where these cases are popping up. And in places like Gaines County, Texas, which is sort of like ground zero, only 1 in 5 or only 4 in 5 or 80% of kindergartners have that MMR vaccine, which means they're way below that 95%.
Okay. And then there are all these crackpot theories floating around social media, like using vitamin A or to prevent it or treating it with inhaled steroids.
Right, exactly. But the bottom line is measles has to be taken seriously. You cannot, be getting information off social media because it's really contagious and it can lead to serious complications, including hospitalization. And as we've seen twice now, unfortunately, even death in young people. So it's not to be played with, and it's not the time to be listening to unproven advice.
Yeah, so please don't mess around with the health of your kids. Vaccinate them to prevent further spread and to protect vulnerable populations.
Exactly.
Yeah.
Yep.
Wow. Yeah. Look, number 3. I've been since we went to this, since we went to the recap, I've been reading number 3. And I don't know what UPFs are and your risk of diabetes. No, diabetes. Let me stop playing. Sugar, the sugar, as my grandmother used to say.
Right.
Are UPFs like UFOs? What's the deal?
No, they're a little bit different. UPF stands for ultra processed food, otherwise known as junk food. So think frozen pizzas, sodas, packaged snacks, instant noodles, all that stuff that's heavily modified and processed, loaded with preservatives and artificial colors and flavor enhancers, all that stuff. So there are many studies, but even a more recent study that shows that eating a lot of these ultra processed foods are linked to higher risks of serious health problems like obesity, diabetes, heart disease, and even some cancers.
Wow, those are the foods that they say affect your mental health, like increasing anxiety, depression, and even memory problems. How would that work?
So, scientists really believe that these additives that we see in the ultra processed foods can disrupt our gut health, the good bacteria in our gut, increase inflammation. There goes that inflammation again,
Hmm.
all throughout the body. And because these foods are often higher in sugar, in salt, and in fat, they are engineered to keep us coming back for more, and people use them, to help increase their mood, right? We've all heard of people who when they get depressed they eat, but actually potentially, as you mentioned, could worsen depression. So it's easy to overeat and it's hard to stop.
So, what can you do? Do you got any tips on that, Doc?
Sure. Well, read your labels. Look out for those foods that have that long ingredients list, and you could just look at them and know that they are not a naturally occurring color. Like
Right.
my favorite Red Hot Cheetos, right? That
Right.
red is not found in nature. Um, then you want to choose more what I call whole foods, foods that have never been processed, things like vegetables, fruits, and whole grains. And then, most importantly, please eliminate those sugary drinks. People, when we drink those sugary drinks, we're actually just drinking straight sugar, additives, dyes, all kinds of stuff. So the best thing we can do is cut out sugary drinks and drink water.
Let me help our viewers with and listeners with another one. I find the more I cook at home, the more I don't need the junk food or any
Yeah.
of
All
that.
right.
Like it takes my mind. It's like satisfying. Not like I sound like a 13. It's like satisfying. But no,
Like a valley girl. Yeah, like.
like like no, it is satisfying. It's not
Yeah,
like satisfying. It is satisfying.
yeah. No, that's a great one. That's a great one. Thanks for adding that in.
Yeah. You know what we
Yep.
got next. You know, we
We're
out of
we're
topic. So what's next?
The weekly debunk. Stopping misinformation in its tracks.
All right, so this week, Becky Bama says, so I heard fluoride has to come out of our drinking water because it's causing all kinds of problems like arthritis, cancer, and loss of IQ. That's what the government says.
I don't know about that. Excuse me, Dr. Mel. Is that true?
It is absolutely not true. Please tell Becky that these kinds of claims that fluoride cause cancer or lower IQ or harm organs in our bodies, there's nothing, no credible scientific evidence that backs that. And here's why. So, number one, fluoride is a naturally occurring substance in nature. It's found in the water, our soil, and even naturally in some foods. The reason that it's added into our drinking water is for our dental health. It really prevents tooth decay, essentially, which can be harmful to your health, and can be costly for families who have to go to the dentist a lot, because their kids' teeth are decaying without
Yeah.
fluoride being present in the water. So, like a lot of things, like salt, like iron, like even water itself, too much fluoride can cause health issues. But we're well below those um, those levels of fluoride, which are monitored very closely by municipalities to make sure that their fluoride is in the right range to be beneficial. And most scientific organizations like the Centers for Disease Control, World Health Organization, American Dental Association endorse using fluoride in the water. So please don't panic. Your water is good. Your toothpaste is good. There's no reason to be concerned.
I guess that's why Becky's a Bama.
She's a Bama.
Becky's Bama. With the
Okay.
last name Bama, you a Bama.
On that note, thank you all. We are going to see you back very shortly, but we're going to move into talking about cancer, a disease, cancer is a concern in the Black community, in all communities, but we know in some sense the Black community is disproportionately affected by cancer, various types of cancer. We're going to hear about that tonight. We're going to talk about myths associated with cancer, the need for screening. We're going to get into treatment. We're going to cover a lot of stuff, but I first want to introduce our guest for tonight. His name is Dr. Otis Brawley. He's a seasoned researcher and the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. Now, he is a fellow and a member of multiple societies. So y'all have heard of like an EGOT, right? Somebody who's had an Emmy, a Tony, Oscar, and a Grammy. Well, he has the equivalent of all that in medicine and in healthcare. So I really want to welcome him and thank him for being here tonight. Hi, Dr. Brawley. Thanks for joining us.
Hi, and thank you for having me, and thanks for that introduction.
Absolutely. Well, you are a top expert in cancer. So I want to just jump right in and talk about the fact that, as I mentioned, we know that Black Americans are more likely to die from cancer than any other racial or ethnic group. What are some of the biggest reasons behind that?
Well, let me start out with first some good news. The peak in the disparity was 1990. And the disparity has gotten smaller and smaller. We don't want to go to math class here, but in the year 2000, for every 100,000 Black people, 250 died from cancer. For every 100,000 white people, 200 died. So it was 250 versus 200. In 2020, for every 100,000 Black people, it was 165 who died. And for every 100,000 whites, it was 150. So we've gone, the difference is now 15 instead of 50 in 2000. It's getting better, and the death rates are going down. Now, reasons why we have disparities are differences in smoking, differences in our diet and obesity. You gave a great talk just at the beginning of this show about the problems with diet and diabetes and ultra processed foods and diabetes. You can say the exact same things about cancer. Okay. So if we, and then of course the third leading, so let's do it in order. Number one cause of cancer in the United States is smoking. We smoke more. Number two is, we call it energy imbalance in the academic world, but it's really a combination of consuming too many calories, not doing enough exercise, and then storing that caloric energy as obesity. It's a three-legged stool: too many calories, not enough exercise, and then obesity. That's the second leading cause of cancer. By the way, we're starting to smoke less, so it will be the leading cause of cancer within the next 5 years or so.
Meaning
Then the third
obesity
leading
will be the leading cause.
the obesity epidemic, which is far
Wow.
worse in the Black community than the white community,
Mm-hmm.
far worse in
Mm-hmm.
the Black female community than the Black male community. But it's a
Okay.
problem. I don't want to be blaming anybody, because a lot of social situations cause these issues. And then the third leading cause of cancer in the United States is alcohol. 12
A
to
lot of people don't
15%.
know that. That is a surprise to a lot of people.
Yeah, 12 to 15% of all breast cancers are due to alcohol consumption.
Wow.
And so there you have the things that we need to focus on to try to prevent disease. And we need to appreciate prevention. And we've actually had a bigger drop in mortality over the last 30 years because of prevention than because of screening and treatment.
Yeah. I think that the fact that the mortality rate has dropped, the number of people dying from cancer has dropped, is amazing, those numbers that you started off with. But another trend I know that we're seeing is younger people are being diagnosed with cancer. So the screening cutoffs
Yeah.
for, or there's the ages to start screening for colon cancer, for example, recently were lowered because of seeing more cancers in
Mhm.
younger people. Why is that? Why is that trend
Yeah.
happening?
And I should disclose, I was the co-author of the American Cancer Society recommendation to lower the screening age. What we've actually seen
Hold
in
on, hold on.
colorectal cancer.
Hold on, hold on. I told you we had an EGOT here tonight, y'all. I mean, he is behind the screening recommendation. So please go ahead, Dr.
Yeah.
Brawley.
One of the things that we've seen is a decline in the death rate from colorectal cancer for all people of all ages. But then when we look at the subset of people under the age of 50, we see a rise. And so it's a weird thing. For people 50 to 70, dramatic declines in death rate from colorectal cancer. For people 35 to 50, dramatic rises. Now, we think that's related to the obesity epidemic. In the United States, among all Americans, 15% of us were obese in 1970. Today, it's well over 40%. We think it's also related to that ultra-processed foods issue you were talking about earlier. Keep in mind, we didn't have a lot of ultra-processed foods prior to 1970. And the way to get around this is exactly as you were saying. The National Cancer Institute has had a program in the past, which I wish they would bring back, called 5 a Day for Better Health, encouraging
Right.
people to eat 5 to 9 servings of fruits and vegetables per day. That pushes out all the bad calories, all the processed meats. By the way, a processed meat, lunch meat, bologna,
Mm-hmm.
salami, those are processed
Bacon,
foods.
bacon,
Bacon,
half
uh,
smokes, hot links,
exactly,
sausage.
exactly.
Yep. Mm-hmm.
We need to try to get these ultra processed foods out of our diet, eat fresh fruits and vegetables to do it. Now, the other thing, and I once did Larry King Live, and he was amazed at this. The World Health Organization maintains a list of things that might cause cancer, things that probably cause cancer, and things that definitely cause cancer. And he used to do
Okay.
all these shows on cell phones because everybody was obsessed with cell phones and brain
All
tumors.
right. Yeah.
It's on the list of might cause cancer. But on the
Okay.
list of definitely does cause cancer is beef, red meat, pickled vegetables. Yeah.
Hold on,
Processed vegetables. Yes.
pickled vegetables? Oh
Yes.
no. I love pickled
Yeah.
onions. I didn't realize that. I
Yeah.
gotta get rid of those.
Yeah. Think of it this way. Pickled vegetables and red meat, to include pork, by the way, the other red meat in our world,
Mm-hmm.
are all on the same list of cancer-causing agents as ultra-processed foods and tobacco.
Wow. Wow. I mean, I
Yeah.
think hopefully that causes everybody some pause, right?
Yes.
We talk a lot about plant-based diets, and I talk about how that doesn't mean you have to cut out meat, just make plants and produce the center of your plate as opposed to, the side attraction and
That's
making the
right.
meat and making the meat the main attraction, right?
We as epidemiologists talk about not avoiding all carcinogens. That's impossible. We talk about managing our exposure to carcinogens. One should only eat red meat twice or perhaps 3 times per week, not twice or 3 times per day.
Right.
One can still have pickled vegetables. One alcohol you could really live without, but if one is going to consume alcohol, no more than 1 drink a day for women, 2 drinks a day for men. And by the way, you can't abstain for 6 days and drink 7 on the 7th day and say it averages out to 1 a day.
Right. Okay, that's good to know. That's good to know. Well, those are and of course, not smoking, period. Does that also go for marijuana smoking as well, which, is becoming
Y-
legal in different places?
Yeah. The federal government has not allowed us to study marijuana the way we've been allowed to study cigarettes. It's a interesting quandary in the law. I can tell you that there are 80 known carcinogens in marijuana smoke, but there are no studies out there that allow us to say that marijuana causes cancer the way we have the studies within tobacco. I can still say that you're inhaling those carcinogens. The other
Right.
issue I can say is most people don't smoke as much when they're smoking marijuana as with cigarettes. That all being said, I would try to avoid marijuana smoking.
Right. No, that makes sense. So y'all heard it here. Do with that what you will. They're carcinogens, cancer causing agents in the smoke of marijuana. It just hasn't been studied as much as tobacco. So we've been talking a lot about environmental exposures. Let's switch gears a little bit and talk about family history, like
Yeah.
what we inherit, right? And a
Yes.
lot of times we don't talk about a lot about family history. Sometimes things in prior generations have been kind of hush hush.
Mhm.
Why is it important to know our family health history specifically as it pertains to cancer?
Sometimes when I'm dealing with a patient, I still see patients. The family history can help me. By the way, when listen to a family history, I'm interested and I'm thinking not just about genetics and what people have inherited from their mother and father and what genes they share with their brothers and sisters and children. I'm thinking about environmental exposures that an entire family might have had. So
Sure.
it's a combination of both environment and genetics, and it can help us a great deal. One of the things I'd like people to try to focus on is have that conversation about what things people in the family have had that might help a man who's struggling with the question of should I be screened for prostate cancer, that might encourage a woman to go get screened for breast cancer at an earlier age. One of the things we recommend in colorectal cancer screening is that people start getting screened not just at 45, but if you have a relative who was diagnosed with colorectal cancer under the age of 55, we recommend you start 10 years before they were diagnosed. So there's some people out there who should start screening at the age of 36 or 37 because they had a relative who was diagnosed in the late 40s. And so you need to know family history for that.
No, excellent point. I can say that's true in my family. I had a relative diagnosed around age 55, and I started getting colonoscopies in my 40s for that
Mhm.
exact same reason.
Mhm.
So that's really key. So helping people to understand what their risk is and when to start screening for certain key cancers like
In the
prostate,
case,
breast, and colon. Hmm.
In the case of colorectal cancer, family history is even more important because a large number of people live in areas of the country where they don't have a GI doc who can do a colonoscopy. Now, I live in Maryland, for example. On the eastern shore of Maryland, there's almost no doctors available to do colonoscopy. People have to drive for 3 hours to get that
Wow.
service. Stool blood testing or stool DNA testing is really very, very good, especially for people who don't have an extensive family history of colorectal cancer. And so if you know that you don't have colorectal cancer in the family, stool blood testing or stool DNA testing is a very reasonable thing to do versus making the 3-hour drive plus the 2 days of prep for a colonoscopy.
Makes sense. Makes total sense. And while we're on it, there's some cancers that occur in a cluster. If you,
Mhm.
for example, the BRCA gene, which I think
Mm.
is known in the media probably because
Mhm.
of Angelina Jolie popularized it. Can
Mhm.
you speak a little bit about what that when you hear the word BRCA,
Sure,
what does that mean, and what does it mean
sure.
for men, and what does it mean for women?
Yeah, well, first there's BRCA1 and BRCA2, and the way we teach this to the medical students is we say, think of BRCA1 as a very long word. It's 125,000 letters. Now, in my alphabet, I only have 4 letters total, but these are very long words. And a
Mm.
mutation is a misspelling of that very long word, and we can actually spell check the gene. That's what we do when we sequence it through 23andMe or ancestry.com. We're spell checking the gene, and if there's a misspelling that causes disease, the BRCA1, BRCA2 mutations increase risk of breast cancer. We all know about that. But in women, it also increases risk of ovarian cancer, slight increased risk in colorectal cancer. In men, it can increase risk of breast cancer. A lot of people don't know men can get breast cancer.
Right.
Virtually every man I have seen in my 35 years who has breast cancer had a BRCA mutation.
Wow.
Uh, then it can increase risk of testicular cancer in men as well. So
Mhm.
knowing that you have these sorts of mutations, and we just mentioned BRCA1, BRCA2, there's at least 12 others out there that we routinely check for nowadays, especially in families that have a large amount of cancer. And you might want to talk to your doctor and see if your family history is significant enough that they ought to go see a genetic counselor who can look at the family history with a lot more time and expertise and decide if they should get these blood tests to look for these genetic
Mhm.
abnormalities that put people at higher risk. And those
Right.
people should get sometimes some of these screening tests. We call them surveillance at that point, but they should get these tests because they're at higher risk of disease that we wouldn't ordinarily recommend people get.
Right. No, that's great. And what I really wanted to underscore is that, if you have an aunt or a mother or an uncle and they all three had some different kind of cancer, that's something that you should be bringing up to your doctor because as you mentioned, it might be important to talk to a genetic counselor. And so you mentioned screenings. So there's several cancer screenings that one can get. Are there ones in particular that you recommend?
Yes, yes. First, cervical cancer screening for women age 25 and above. And that can be the pap test or it can be a test for human papillomavirus infection. It can be one or the other. The pap test needs to be done every 3 years. The testing for HPV viral infection can be done every 5 years. We love to stress that test because there are about 4,000 women who die from cervical cancer in the
Wow.
United States every year. And there's a study that's looked at women who die from cervical cancer and finds that virtually none of them had screening within 10 years of
Wow.
their diagnosis of the disease. It is a screening test that, unlike many other tests, is very effective at preventing disease. Breast cancer screening. Uh, Most organizations are recommending that women get breast cancer screening for sure, starting at the age of 45, and some may want to start at the age of 40. Whether you get it every year, every 2 years is something you should talk to your doctor about. And you should try to get high quality mammography. And I say
Mhm.
that because there is low quality mammography out there, especially poor people and people who live in poor neighborhoods. We need to be very careful, for example, when breast mammogram vans come to the neighborhood. They frequently give a lower quality of mammogram versus a bricks and mortar facility. And when I say lower quality, A high quality mammogram involves looking at last year or the year before's mammogram and comparing it to the one this year. And many of these mammogram vans don't even try to find previous mammograms. And indeed, I've been worried that our message on mammography and breast screening is a little wrong. It's not get a mammogram, it's get into a program of regular high quality mammography that we should be saying.
Right. That makes
We
perfect sense. Yeah.
Mhm.
So going to a facility, and if you can go to a facility the same one each time, if
Yes,
possible, then it's easy to make that comparison year over year and see changes, because that's really
that's right.
what's being looked for. Yeah.
That's right. We've already talked about colorectal screening. People
Mhm.
at normal risk, meaning they don't have it in their family or in their family under the age of 60, ought to start screening at 45. And the screening tests are colonoscopy, which can be done every 10 years, but it involves a prep that takes about 2 days and a lot of diarrhea. Sorry, I keep talking about stool this evening. It also involves anesthesia. You're out for about 30 minutes while they put the scope in and look
Mhm.
around the colon. Or stool blood testing or stool DNA testing. Stool blood testing needs to be done annually. Stool DNA testing needs to be done every 3 years. And so
Yep.
it's really the person's choice. Most people want to get the colonoscopy if it is available, but as I said,
Mhm.
there's certain areas of the country and indeed in certain states where getting a colonoscopy is almost important. Then there's
Right.
the issue of lung cancer screening. People who have smoked in the past, and again, we urge anyone who is an active smoker to try to quit. We know that there can be improvements in your health in terms of cardiovascular disease within 3-4 months of stopping
Right.
smoking. And risk
Mhm.
of lung cancer goes down 10 years after you've stopped smoking. But people who have a history of extensive smoking should talk to their doctors about getting a spiral CT screening of their lungs. And that should be done every year for people starting about age 50 who have this history of smoking. And if they're still smoking, they ought to get the
Definitely.
screening, but they ought to get
Mhm.
into a program to try to quit smoking as well. And then the last big screening test is prostate cancer, which
Mhm.
is the most complicated.
Right.
There are a lot of doctors who think prostate cancer screening saves lives. However, let's be truthful, it may save lives. And all the major organizations, be it the American Cancer Society, and I helped write that recommendation. Let's go to the American Urological Association. I did not write their recommendation. Their recommendation is within the physician patient relationship, where physician and patient know each other and the physician understands what the patient is concerned about. The physician should explain the potential risks and potential harms which do exist and the potential benefits, and the patient should be allowed to make a decision as to whether they want to be screened. And this discussion should start at about the age of 45 for Black men and 45 to 50 for white men. But again, it's for informed decision making. No man who wants to be screened should be criticized. No man who doesn't want to be screened should be
So,
criticized because we have this question mark. And if a
yeah.
physician and patient decide to do it, that's wonderful, as long as the man is aware.
So, well, I guess I should ask. First of all, we're talking about screening for prostate cancer involves the blood test for
Yes.
PSA or prostate specific antigen, as well as the digital rectal exam. So the finger
Yes.
test, right, that your doctor
Yes.
does. So
Yeah,
together, that's the prostate screen, and
we need to do both.
yeah, together. And so, but if somebody, we know that Black men disproportionately get prostate cancer. Um, if what if they have a family history? You know, how should that inform their decision as a Black man of a certain age who may have prostate
Uh,
cancer in his family?
I'm very understanding of a man who has seen other people in his family or even other friends who have had prostate cancer and who decides, I want to get screened because I'm going to hope that screening actually will be beneficial to me. I think that's a very reasonable decision for a man to make. My issue is many people will push prostate screening on men and promise that there is a benefit that science has yet to show us. You know, the one study, interestingly, the one study that showed us that screening saves lives, number one, it was a study done in Europe. It was not a study done in a large group of Black men. And it showed that screening saved lives in 2 countries, but did not save lives in the 5 other countries that the study was being done in.
And
So
is
we've got
this
a problem there.
yeah, and is this because prostate cancer is very slow growing? Like, explain a little bit, like,
Yeah,
why is it so clear for other
yeah,
cancers, but for prostate cancer, it's, as you're mentioning,
yeah.
really kinda up to the patient?
Yeah, there's a number of different types of prostate cancer. And the way I sometimes explain it to people is think about cats. There are many men, indeed, the majority of men who we diagnose with prostate cancer have kitty cats as a cancer. But there's these group of men out there who have lions and tigers. The lions and tigers will kill. The kitty cat cancers are indolent and are never going to kill. And
Very
indeed,
slow
one
growing.
of they're so slow growing and non-aggressive that they will never kill. One of the major things that's happened over the last 25 years is in 2000, if we screened a man and we diagnosed him with prostate cancer, we would say you need to start treatment within the next 2 weeks. Now, over half of all men who we diagnose with prostate cancer, we have some tests that we can do in the laboratory, and we will say, Mr. Jones, this is one of the less aggressive cancers, and we recommend that it be watched as opposed to we treat it. And now, many men who have heard this "you must be screened" message are very uncomfortable after they've been diagnosed with "you should be watched." But indeed,
Right.
nowadays, 60% of men who are diagnosed with prostate cancer through screening start out being watched, and the majority of that 60% will never get treated for it. They'll just be watched on a regular basis. Now, watch is not ignore. We have problems that some people say here it should be watched so they go away and don't come back. But prostate cancer screening and treatment is incredibly complicated, and it's not something for TV commercials. And I especially worry, I'll be very honest with you. You said I was a straight shooter. I'll be a straight shooter tonight. There are some doctor groups who pay ministers $2,500 or $5,000 to get the podium
Wow.
on Sunday afternoon, and they do this free prostate screening in the van out in the parking lot or in the somewhere in the church basement, and they're making a promise that prostate cancer screening would be beneficial when the science tells us it might be beneficial.
Right. So it's really a decision to make with your doctor, understanding that you might just have a mild, even if diagnosed, you might have a mild form that doesn't require treatment. And that's just something to be comfortable with. But there is a chance that it could pick up one of the more aggressive ones where you would need to be treated. So
That's
it's a
right.
decision to be made with your doctor.
That's right.
I
I wish every
yeah,
man who is being screened knew that beforehand,
right,
because
right.
frequently they find out after the diagnosis.
Right. No, that makes sense. Well, listen, we have to bring the audience in. I know there have to be questions out there. So I'm going to ask Wayne and Lila to come on back and let us know what's going on in Be Health Empowered land out there.
Um, the prostate cancer conversation is a whole show.
It
Yeah.
is.
Oh
It
my
is.
gosh.
Yeah.
But
Yes.
but everything you just said, Dr. Brawley, is so enlightening because I think we have been scared into a lot of these screenings. So yeah, that's a bigger conversation. But
But I do want to be clear that everything else other than prostate cancer that Dr. Brawley talked about are recommended screenings that clearly save lives.
That's right. You know, in the case of breast cancer screening, we have 12 prospective randomized trials going from 1963 through the 1990s in several different countries that all tell us that mammography screening saves lives, clearly for women over 50 and probably for women over 40. And every one of these, we have a prospective randomized trial. And I told you about the problem with the one trial in prostate cancer.
Okay.
Right. And that's because those other cancers, when you catch them early and treat them, it makes a difference for sure. Yeah.
Dr. Brawley, what was the name again of the lung cancer screening?
It's called spiral CT. Sometimes it'll be called low dose spiral CT. And it's a very simple test. You have to have a special CT scanner with special software, but the patient lays on the table, takes a deep breath, and has to hold the breath for about 45 to 60 seconds while the CT scanner does an X-ray of the entire lungs.
Okay. Okay.
Well,
yeah, I have another question.
Go ahead.
Dr. Brawley, we spoke about the high level mammography, that was great information because I had never really heard it broken down like that. But say I'm in a lower social economic situation and my only access is to the mobile screening. I should do that, yes?
Yeah, poor screening is better than no screening. Yes.
Okay, that's all. That's all I wanted to get at.
Yeah.
Okay.
But I think it's important, though, to advocate and say, if that is your only option, hey, can you please pull my mammogram from the last time you screened me and compare it? Or let them know I got my last mammogram over at, hospital for the special people, or, trying to think of a name, hospital X across town.
St. Elsewhere.
Can you please, St. Elsewhere. Thank you. St. Elsewhere across town. That's where I got my last mammogram. Please make sure to compare it to that one.
Okay. And then to piggyback on that, Dr. Brawley, are there any resources for folks who may not have, outside of that, a mobile screening that may be offered at the church? Are there other resources for folks who may not have insurance? Are there places that can help that you're aware of?
It is getting harder. It is getting harder. Now, for breast, cervical, and colon cancer screening for people who don't have insurance, in many states, they have partnered with the Centers for Disease Control and Prevention, and they have special programs that allow for screening for that, usually through federally qualified health centers. Prostate cancer screening and lung cancer screening are a little bit harder to get for people who don't have insurance. And I also worry about people who don't have insurance who then find out they have an abnormality that needs to be worked up. So please try. I want people to think about health, and I want people to think about prevention as well as screening. But please try to think about getting into a system that's going to take care of you if you have one of these abnormalities.
Right. And just a commercial for federally qualified health centers.
Yes.
They're also known as community clinics or free clinics. And, they provide a range of services on a sliding scale, meaning you pay what you can afford. If you can't afford, then you don't pay. And, when Dr. Brawley says get into a system, that's a system that has multiple different kinds of providers who can help address what your needs are, often are available in rural areas. So even if you're not in a place where there are a lot of doctors, oftentimes you might still be able to find a community health center.
And there should be no shame around that. There should be no shame. There are entrepreneurs and gig workers and folks whose income ebbs and flows. You still got to take care of yourself. So tap in.
Exactly.
So, and the gig workers include actors, musicians, you know, Uber drivers, those types of jobs and those types of careers. I want to cut in here because I have two great questions from one of our great people who join us sometimes. Richard Goodjoin asked these two questions, and I'm going to pose both of them. Can the increase in cancer also be related to microplastic exposure as well?
That's a really good question. The answer is it might.
Okay. And then what's your opinion of Cologuard?
Cologuard? I have a positive opinion of Cologuard. Cologuard is the stool DNA test that I mentioned stool DNA earlier. Right now, there's only one brand out there on the market, and it's Cologuard. And you collect a sample in what looks like a Dixie cup, and you send it by UPS to a laboratory up in Wisconsin where they analyze it looking for 21 different tests. 20 of the tests are different genetic markers, and one test is looking for blood in the stool. And then Cologuard will send a report to your doctor and to the patient saying there's a problem here, meaning you need to get a colonoscopy now to see why there is a problem. Or Cologuard will say there is no problem, you need to repeat this test in 3 years. It is a very reasonable test, as is stool blood testing done once a year, which costs about $20. Cologuard costs about $500. And colonoscopy, which can be done if you have a normal colon after a colonoscopy, it needs to be repeated every 10 years. That costs $2,000 to $3,000 depending on where in the country you are. Insurance will pay for all of those for screening tests. Part of the Affordable Care Act or Obamacare is that if you get any of these screening tests that we have talked about this evening, if you qualify for the screening test, your insurance, if you have insurance, should pay the whole thing without a deductible.
Yeah.
Oh, wow.
Very important.
Yes.
No out of pocket costs.
So that answer brings us to another question that we have on the board from Beryl Anderson West. As some women have dense breasts and insurance does not cover a second mammography, if the first one can't see anything, are there any monies available to get the second mammography, and which can also see through dense breasts?
The dense breast issue is you could do several shows on that one.
Yep.
The younger a woman is, the denser her breast, and the aging of a woman means that she loses density. And when I do a mammogram on a 40-year-old woman's breast, I'm looking for a white tumor on a white background. That white background is density. Right? And if I do a mammogram on a 70-year-old woman, I'm looking for a white tumor on what is really a black background. And as a woman ages, we go through shades of gray from black to white. Sometimes you do a mammogram on a woman who's 40 and you just can't see anything. You might, if you suspect there's something there, you might want to do an ultrasound. Now that's that's diagnostic, that's no longer screening, and the insurances deal with that differently. But that's a difficult question. We usually don't repeat mammography on women who have dense breasts. We go to ultrasound. Sometimes we'll go to MRI, and there's now molecular breast imaging, which is a nuclear medicine test we sometimes go to.
Let me tell you, that MRI thing for the breast
to stay in
is no fun. I talked to Dr. Mel about that recently. I had to do that because of my risk factors. Whew.
Was it just claustrophobia from the machine?
It's the
From being in the machine?
positioning. It's
Oh, okay. Got it.
It's the whole thing. Dr. Brawley, what gives you hope when it comes to fighting cancer and saving more Black lives?
Well, I think in the United States as a whole, the death rate has gone down 34% since 1991. That means the four of us, each of us, our risk of dying from cancer is a third less than it was for people our age in 1991.
Okay.
So that gives us hope. For Black people, for Black men, the death rate has gone down by more than 40%. Wow. And that's a lot. Now, a large part of that is because of people not smoking or people who were smoking stopping. A large part of it. And I've already told you that while we've got this decline in cancer death rate, what's pushing it up would mean the reason why it isn't declining even more is this obesity epidemic. The fact that 15% of us were obese in 1970, and it's over 40% today. Among Black women, it's closer to 80% of Black women are either obese or overweight. You know, we know some of the things that we can do to help continue this decline in mortality, and they involve prevention, diet issues that we talked about, prevention. That gives me a lot of hope. Some of our screening tests are getting better. Some of our treatments are getting better, and that gives me a lot of hope as well. Now, we can talk about what scares me, and that is that there's a lot of people who aren't able to get all of these wonderful things that we're talking about, be it prevention, appropriate screening, appropriate diagnostics, and appropriate treatment.
Right. And you've inspired me to do a show on obesity because it's been a while, I think, since we've done it. So I think it's probably time. And unfortunately, I think it is time for us to sign off soon. I can't believe this hour went so quickly. Dr. Brawley, thank you for all your expertise and all your advice. We greatly appreciate it. Thank you, Be Health Empowered Family, for all the great questions for Dr. Brawley. And of course, my co-host, Lala and Wayne. See you next time. Thanks as always. Remember, until I see all of you, be wise, be well, and be health empowered. Thanks for joining in.